Come and get started on a new mission, a new direction, a new intention. Welcome to 5.8G Alive at Connections 50 Plus. I am Terry-Ann Joseph Brathwaite.
And I am Jennifer Gibbons Joseph, catering to all your prospects in the third act of life.
Economic well-being, social gratification, personal fulfillment.
Join us on Wednesday at 6 p.m. on Connections 50 Plus Facebook page, YouTube channel,
and on Gael the Caribbean.
Good afternoon, everyone across the Caribbean, Central America, and South America, because we have Guyana and Belize on. This is Wednesday afternoon, and you are tuned in to 5.8G Alive by Connections 50 Plus. I am Terry-Ann Joseph Brathwaite, one of the co-creators, and I'm so happy to be here this afternoon. With me,
I am Jennifer Gibbons Joseph, the other co-creator of Connections 50 Plus. Welcome again and good evening to all you out there. Terry-Ann to the Caribbean and everybody that listening to us this evening. Welcome.
yes. So Jennifer, we in October, and as everyone knows, we have declared the 1st of October was the day of the elderly persons, and
Yes.
we have declared the month. And last week, Jennifer Rouse really set the ball rolling in a really dynamic way. Thank you for your responses, and we're going to see Dr. Rouse again. So Jennifer, wasn't that a great time last week? What was the main thing you got from Dr. Rouse?
Just being alive, reaching something, being a young, what is young old?
Yeah.
And enjoying life, taking care of yourself and enjoying life. That is what I got. I could have related very easily to what she said.
Yeah. Because remember, we are following Daching's The Sky Gets Dark Slowly. And his first thing that he said we had to be warned about was the importance of community. Because as we get older, a lot of our friends, our spouses, our parents, they may die. And increasingly, less and less people will be around us. So Dr. Rouse certainly aroused that community comes in many ways, and mindset is important. But today, we are moving on. And we have a really important guest. We are going to now talk about us medically.
Medical.
Something we don't like to talk about. You know, fact of the matter is that we are in the 5.8G, we are the third act of life, and how our bodies respond will differ. And yes, you may have been fine for the last 60 years, but we need to pay attention and think a little bit ahead about what's going on. So Jennifer, who is our guest? Do you want to talk a bit about, you have a special relationship with the guest, so.
I am very happy, Terry, and Dr. Lorraine Patience has agreed to be a guest on our show. And yes, Dr. Patience is my doctor, but what I like, and when we spoke about getting a guest, not just a medical doctor, we also wanted a medical doctor who's a gerontologist. You know, we heard, and this is great because we had Dr. Rouse in her field, who's also a gerontologist, and you all realize they have different fields. Those who specialize in gerontology. So you may be a medical doctor, you may be a psychologist, you may be, in different fields, but your focus is on gerontology.
Yeah.
You know,
and the thing is, if people are of the US side, they would also understand she's a geriatrician. I have a pediatrician, she's a geriatrician. That's the US word. So
So we do, so Dr. Patience, you're gonna hear her in a while, really covering all the aspects of our, our health. We heard a lot, and she would mention it. And I would look. Let me leave it for you for when she comes on, for you to really hear all what she has to say. And as usual, we will appreciate if you send your questions in, and we'll respond to it.
Yeah.
So let's introduce Dr. Patience to you now.
Being in tune with your own self.
Right. So as we mentioned, we have today with us a medical doctor and a gerontologist. So let me introduce to you all Dr. Lorraine Patience, and we are so happy that doctor has taken time out to come and share with us and tell you all what you can do at this stage in our lives to really maintain good health. And I must add that I'm so proud that Dr. Patience is also my doctor, you know. So Dr. Patience, to start, I would really like you to share with our audience. You know, and I mentioned, in addition with you being a medical doctor, you're also a gerontologist. And could you share with us in terms of that combination and how great it would be for you to help our age group, our cohort, which we call the 5.8G, 50 to 80 generation?
All right. Yeah, so, well, primarily I'm a general practitioner, so I can see everybody, but I have a particular like for our, you know, our older population. So, you know, I don't even consider 50, 60, 70 old, but we are all aging. So that's where the gerontology part comes into it. So that really is just the care of anybody over, we say 60, but our older population. And we have young, old, and then older, old. And I always, you know, was very close to my grandparents. So from young, I, you know, felt a real connection with that cohort of our population, and that has just transformed my working practice then. So although I do see everybody, and it's nice to see a young person or a baby from time to time, I do quite enjoy spending time with you know, the older cohort. You get so much information from them in addition to being able to help them in terms of their medical needs. So it really is quite an enjoyable group to work with.
Dr. Patience, I have found, and here's an example, you know, we were told that we should at least visit our doctors once a year. Is that the same when we reach this stage of life? Would you recommend a visit once a year, or and not only when we feel in a pain? What would you say to our cohort in terms of that type of, you know, visiting the doctor?
Yeah, so it's definitely prevention is better than cure, right? So visiting a doctor regularly is important. I would say at least once a year. Certainly if you have medical problems. So if you have comorbidities, as we, you know, everybody knows that word now. So diabetes, high blood pressure, heart disease, then you should be seen a little bit more frequently. Every 3 to 6 months, you should be seen by a doctor.
Oh. Terry, and you want to come in here, I know, in terms of, especially with your parents too.
Yes.
You know?
Hi, Dr. Patience. I tease Jennifer a lot, and they like to dismiss me because I'm going to be 60 in 2 months. I think I'm getting in there. And one question that I always have is and this is in terms of maintaining health. Are there different protocols, screenings that persons must begin to pay attention to as we get older to ensure that at least we know our status and to be able to develop more? Is there something different to the medical that I would have when I was 30, 40, 50 to the one that I would have when I'm 60, 70, 80?
Yeah, so most people, and you would continue that even as you age, you do your normal checks for diabetes, for cholesterol, and well, your blood pressure, those things. And even women would start earlier doing mammograms and pap smears, depending on your personal history and your family history, that those tests may continue as you get older. For some people, we actually recommend that it stops later in life. It's not as necessary to do it.
Yeah.
But then there are some more specific ones. So by the age of 50, and that includes your cohort, so
the young
50,
ones,
we start to look at other types of tests.
Yes.
Colonoscopy, for example. to that we start to screen at about 50. So generally, anybody over the age of 50 should have had some sort of screening test for colon disorders, whether it is a stool test to check for blood, or even as far as a colonoscopy, a camera test that, that can detect any issue with regards to colon. Men particularly need to be a little bit more aware of prostate disease. So that screening should start at 40, but to be honest, to get many men in at 40 to do that screening is unusual. Yeah. So definitely 50, 60, we are making sure we're doing screening for prostate disease, blood test, and physical examination. And then the other one in this cohort particularly is bone density. A lot of people forget about that. And that's one of the bigger things as we get older, potential of, because of balance issues and other things, lightheadedness, tripping, falls are a big problem. And certainly if we have reduced bone density, we're at high risk of breaking bones. So that's another, in terms of our screening and medical, should be done on quite a regular basis so that we can pick up any of these issues earlier rather than later when we've already had a fall and broken a hip, because that's preventable.
Yeah. How often would you do a
screening?
How often would you do a bone density test?
Again, depends on the individual. A lot of, they would say yearly over the age of 60, 65, and in women particularly, once you cross menopause, you should do it. But there are people who you could extend that a little bit, do it every 2 years. If you have certain medical problems on certain medications, for example, steroids, if you have an autoimmune disease or something like that, then those people need, to be screened at least once a year, because being on certain medications puts you at risk of decreasing your bone density. And it's things that we don't even realize too, things like that we all take, you have some acid reflux because we eating curry and thing, and you're taking Nexium, without the doctor knowing, and all of those things can, it can affect your bone density long term, so we have to, and that's again why it's a good idea to visit a doctor regularly.
Okay, and if I can ask, and again, my history is that I have 3 octogenarians in my care. And they're at different stages of health concerns. One of the things that interests me is screening for dementia and Alzheimer's. Most people, it seems, discover that they have a condition after some incident has occurred. How should we approach our mental care in this cohort?
So because of what I do, a lot of times, once people start to hear memory, the word Alzheimer's or dementia is very scary. So as soon as we see that, people, take a step back. We don't want to know about that. That didn't happen to me. So many times I approach it as, one, you need to be aware of yourself, but also it is a lot more picked up by your family members. So many times it's a family member or a close friend has instigated some sort of screening, so you should really go to your doctor and check that, and just make sure everything okay. I approach it as, you're coming to see me, for everything, right? So it's not only I'm checking you physically, I'm going to do a cognitive screen and check your memory so that it doesn't, the person doesn't feel like, they're being, picked on, and that fear exists.
Yes.
Is a very, very difficult thing, and it's not something that is routinely done unless there is some sort of red flag raised. But ideally, it should be part of our regular screening once you reach a certain age. It doesn't have to be 60. Certainly by 75, people, medical professionals should be asking specific questions, not only to the person, but to their close relatives who they're living with, to see if we are missing anything that we could potentially put things in place from before. And it's not only put things in place in terms of medication, but what do we need to look at? If this is what we're dealing in the early stages, do we need to make decisions regarding potential future decisions, right? Financial decisions, home decisions, or, all of these things. And the earlier we can do these things, when the individual themselves can have a role and a part to play in that decision-making process, it makes a world of difference later on to everybody involved.
Yeah.
So
one of the things that I would like to do, because, and this is something that is real to me, I have no fear of dementia and Alzheimer's, because the 3 octogenarians that I deal with all have dementia. They all deny it. I am not bothered by that. But I want to talk to our cohort while we have cognition, because we will do the mammograms, the prostate tests, and the different screens. But it seems to me that the main challenge for quality of life going forward is your cognitive competence. So is there actually a screen that I can go to my doctor and say, I want to begin screening for my mental cognitive competence at 50? Is there an actual screen?
There is, but you will pass it with flying colors, right?
No. Yes.
But yes, there is a screen that most GPs will do, called the mini mental state exam. And it's quite it's simple. You're answering questions about your location, your date. There are a few things where you spell backwards or count backwards. You have to draw, you have to write, you have to remember, short-term memory. So, and it doesn't take long, to be honest. If you're accustomed to doing that test, it might take maybe 20 minutes, right? So it's not extensive. And that's what we use as a basic screen. There are much more detailed ones so a lot of people who might score well on the screen, but what they are telling you or what the family is telling you is not matching to what you're seeing on that objective test, then you have to go into more in-depth testing. And that's generally not done by the GP. That needs to be referred on to, in our case, a psychiatrist or a gerontologist who is accustomed doing those sort of screens. But yes, you can request a MMSE, which is a mini mental state exam for basic cognitive screening. And because it's a quick test and that kind of thing, it really, but I do think in a younger cohort of our cohort, it really misses a lot. So if you're quite early, or dementia or any kind of cognitive issue, you can miss a lot. But that's why it's not only that test, it is you listen to what the person is saying, you listen to what the family is saying, and then you're able to decide, okay, well, does this require escalation to more investigation or something like that,
Okay.
Dr. Patience, is it a fact that you can delay the onset of dementia or Alzheimer's if you do certain activities like maybe the puzzles and you read a lot that there are activities that can be done to delay, and if so, how long that delay would be for?
So I'll answer that kind of in 2 parts, right? So definitely, all these studies have shown that it can be delayed. And particularly the most effective way of delaying the onset or even slowing down the progression, if it's already started, is by keeping as active as possible. And that would include physical activity. So, really getting out there and being active. Mental activity, and that includes things like the puzzles. So when we talk about mental activity, it could be from word search to Sudoku to matching puzzles, building a normal puzzle. It could be playing cards. It is learning a new instrument. It is doing music, listening to music, So any form of stimulation of the brain is what we want to be doing, and that is mental activity. And the more we can do in different ways. So it's not only about, oh yes, well, I do word search all day long, but you need to do word search and something, because every different way you can use your brain, the brain is a muscle. So if we can exercise that muscle, exercise each part of that muscle, it is much more beneficial. And we know that doing those things can delay the onset or slow down the progression. And then, you know, the social activity part of it as well. So we have physical activity, mental activity, and social activity has been shown to really improve quality of life and delay the onset and progression of cognitive decline, which has been, you know, such a great problem over the last 2 years with COVID, because we were told we can't socialize, you know, and I think that has had a huge negative impact on the cognitive, on everybody really, but particularly the older cohort of every population, because we weren't able to have that person-to-person contact. And I think even doing it over FaceTime or WhatsApp or Zoom or whatever is not the same as socializing, you know, like we're accustomed to. We had to do it, but hopefully one day we'll be able to get back into the social activity, because it really, you know, being part of a club or being involved in your church or doing anything where you're around other people, it is very important for your entire, you know, cognitive self. So definitely we can delay it. In terms of how long we can delay it, there's no, you know, set. They haven't been able to figure that out. We know it just delays it, but it depends on how early you started that. Because I tell people, you know, it don't make sense to wait till you're 60 and you're retired to become active. Try and be active in your earlier life, because the earlier you could do something, the better. It's never too late to start. You know, I know people in their 70s and 80s who learn how to use a computer or learn a new instrument. So all of that is helpful. It's never too late to start. You know, the whole thing is just be as active as you can be in those different ways for as long as you can be, you know?
Yeah. Dr. Patience, if I could ask one other question. You mentioned, and I am now getting into yes, there's the preventative side, get the activity, mental, social, emotional, all of that. But the actual diagnosis that something is wrong, you made a statement there, that is usually done by a specialist, a psychiatrist. Would you agree that perhaps the fact that that professional, a psychiatrist, which comes with so much baggage, you're mad, something wrong with you, prevents people from going to investigate? And could you tell us more about what exactly is done, what kind of testing is done to determine the extent to which you may have cognitive decline?
Okay, so, but just to be clear, most GPs will diagnose as well. So you don't have to reach the stage of a psychiatrist, right? Our mental health states that it should be a psychiatrist in terms of our legal framework. But, you know, that's semantics, to be honest. But many GPs will diagnose and initiate investigations and management. So many GPs will do that. So not everybody reaches to see a psychiatrist, and I think exactly for that reason, because there's a stigma associated once you hear psychiatrist, right? But you know, it is one of those things where cognitive issues, specifically dealing with dementia, still falls under the realm of, you know, the psychiatric specialty or the neurologist. So many neurologists, so brain specialists, will also diagnose dementia. But in terms of the investigations, you would do the in-office screening test, so which is taking a history and a physical examination and a cognitive test as well, whether it be a short one or a long one, and that would be followed then by a series of blood work, so blood investigations to rule out any other cause of any cognitive issues, right? So because you can have an undiagnosed thyroid problem that can cause memory problems or behavioral change, etc. It could be a vitamin deficiency, a vitamin B12 deficiency can cause similar things. So we have to do a series of blood work to determine whether there isn't any other physical medical cause of your cognitive problem. And also the other investigation is imaging of the brain, because we assume, you know, it's a cognitive thing, it is a brain issue. And we want to rule out, have you had a stroke that went undiagnosed, or, you know, we may have known you had a stroke, but that strokes in effect are sort of like brain damage and can cause cognitive issues. But we also have to make sure it's not anything else that could potentially be corrected in the brain. You know, people have had, especially if you present quite earlier in life, in your 50s or early 60s, we have to really make sure it is not a physical thing. You know, they've had people who presented with memory problems and personality change, and everybody's saying they have dementia and thing, but you scan their brain and they have a tumor there, you know. So we have to do those blood investigations and the scan of the brain before you can say for sure what the diagnosis is, you know, what the type of cognitive issue is.
Yes, I truly appreciate that explanation, because so many people, apart from the fear, you know, I just don't want to explore this area, but you're quite right. It may not be dementia or Alzheimer's. It may be something else that you can very easily fix and you know, have a good quality of life. Good. Jennifer, you're going to say something.
Yeah, no, actually, I was going to mention similar to what you said, Terry-Ann, because when Dr. Patience spoke about blood tests, you know, you hear many, and we're talking again about our age group, many would say, all these tests, what's the sense doing all these tests? It costs so much money. And they may tend to either not do it, not take the doctor's advice, all based on the fact that they just see it as just a blood test and a lot of money being spent. But the information you just shared, and a lot of us, you know, when they chat or gossip, they're not really speaking about, you know, things that they factual, you know, matters like what you just mentioned. So it's good when you mention all the different things that can come up, can be revealed. And it makes a big difference in your mindset. If I know I do all these tests and you could rule out the Alzheimer's and a lot of the illnesses that may have me very nervous and very anxious about. So I just want to reinforce, and for our listeners, definitely doing those blood tests and the scans that the doctors recommend, that is so critical. You know, for us very early, some things could be detected or be removed, or you know, that you won't have to be so anxious about. So yeah, I just wanted to reinforce that. There's one more question before Terry-Ann, about depression. You know, and you mentioned during the pandemic, and a lot of our cohort will ask us about the depressed, and when we spoke about the loneliness. Would you, depression is a medical condition, and what can be done about that? Let me just ask the question like that.
Okay, but I think it's a very good question, because, you know, loneliness and depression are a huge problem, you know, as you get older, right? Particularly after retirement, I find, when we sort of, you know, you've crossed one stage into a next, and sometimes your purpose in life, you think all of a sudden is no longer there. You know, you don't have to get up and go to work. And so I've seen that post-retirement quite a bit, that people begin to get depressed. So it is a big problem. It also manifests not only as depression. Everybody thinks depression is you lock up in your room and you're crying all the time. But that actually, most people don't present that. What people come to my office and say, I don't have any energy I just don't feel to do anything. I'm having problems sleeping, quarreling with the children, nobody could do anything right. And when you get down to it, it is that it's depression or anxiety, because they are quite closely linked, right? Especially in these times. And it is a big, big, big problem. And even ties back in with the dementia as well, because there are many people who it's not actually dementia they have, it's pseudo dementia because they're depressed.
Mm-hmm.
So it's, it is and again, because of the stigma attached to anything to do with mental health, we don't, we're not going to go around and say, for the most part, that we're feeling depressed or we're feeling anxious. We might say it in our close, family and friends, but a lot of people just say, okay, well, I'll deal with it. It will pass. And unfortunately, for many people, it doesn't pass. And what people don't realize is these things are just like diabetes or high blood pressure. It's your body not working properly. It's not your fault, right? It is depression and anxiety have to do with a hormone, a chemical imbalance in your brain. And you can't, for a great deal, control those things. So seeking help when even if you don't think it's that bad, we don't want to wait till it gets that bad. It is treatable, it is manageable with talking to somebody, counseling, and if it need be with medication to help rebalance those hormones in your brain. And yeah, I think, in Trinidad, people don't like tablets, right? Nobody wants to be on tablets because we think as soon as we start a tablet, we'll be on the tablet for the rest of our lives. I can't handle taking a tablet forever. That's not the case. We take people off their pressure tablets. We take people off their sugar tablets. Nobody starts, on a tablet saying you have to take this for the rest of your life, for the most part, So and the same thing happens with depression and anxiety. A lot of times we can be on medication for shorter periods, be it 6 months, until you get back some sort of balance in your body, and then you could try without it. But it is a big, big problem, and it's a problem we don't want to address because we feel that shows some sort of weakness or vulnerability. But we, unfortunately, we need to get over that. It's like anything else. If you're not feeling well, whether it is from a physical point of view or emotional, psychological, mental point of view, you should trust your doctor enough to go and talk to them. If you don't trust your doctor, find a different doctor. And we deal with it, because at this stage of life, it's about quality of life. And if you don't have a good quality of life, or if we're not trying to have the best quality of life in these golden stages of your life, then, we need to do something about that.
Yeah, I have to endorse, and I wonder sometimes, and I am speaking purely as a layperson who has 3 old people that I'm taking care of, if sometimes, and I may be putting you on a hot spot here, sometimes it is good to switch from your lifelong doctor, who may be so accustomed to you as you were and have been, that when changes begin to come slowly, they probably not taken as seriously until something drastic happens. I'm not advocating that, but that's an opinion that I hold. Is there wisdom to that?
I think it's possible. I do hear people tell me all the time that they with the same doctor for a long time, and it's exactly what you've just said, the same kind of sentiment that they think they know me so well, but but I think that is as well an individual thing. I think there are doctors who have been your doctor for the last 50 years, and they will be very on the ball and recognize it could work both ways. They know you so well, come into their office and you're not looking quite right, and they will pick up on things, So I think that's quite an individual thing. I wouldn't, dismiss it, but I could see the opposite side of it as well, where they may be more equipped to pick up on a change in your personality or demeanor that somebody you never met before or don't know as well. So,
Dr. Patience, I want to switch a bit to the men. Again, it's normally said that the women live longer than men. And a lot of different reasons are put forward for that. But going back to the health part, is it so because men tend not to go to do their regular visits or don't take care of their health as much as women? In your experience, in your what do you think may be the reason for men you know, going before the woman or getting sick more often, you know, that sort of thing?
There's so many factors with that. Yes, the health-seeking behaviors. So women will go to a doctor quicker than a man, right? So that does contribute. So maybe, you know, diagnoses are made later in comparison to women. They also have a lot of other diseases that may affect them and a lot of lifestyle decisions, smoking and alcohol earlier in life that can affect their well-being later on in the later years. So yeah, it's multifactorial that. But I find, particularly now, I find younger men seek medical attention quicker. Mm-hmm. So I don't know if that trend will continue throughout their lives. But I have a lot of younger men who come just to do their checkups. Nothing particularly wrong. They just want to check up. And maybe in previous decades, that wasn't as common. I don't know. I wasn't really practicing in those decades. But now, definitely, you know, in the over 60s, I would say I see a lot more women than men. And many times, you know, you still have where the men come because the wife make them come or the daughters made them come. But I do think we may see a change in the health-seeking behavior, you know, in terms of the gender differences in the decades to come, because I have a lot of younger guys in their 30s and 40s just coming for checkups. So hopefully that will change.
Yeah. Doctor, I want to endorse that. And I think it's a good sign for the simple reason that I have a 22 and 29-year-old sons. And amongst them and their friends, there is a lot of discussion about their health, their well-being, and they seek checkups, medical, you know, what is going on with me? I have to go to the dentist, I have to go to the doctor, and it's all preventative. So it is hopeful that we may have a future cohort that is the men are as healthy as the women going forward. I can certainly endorse that.
That's good.
Yes. I want to add another issue and ask the question, what are some of the concerns? And because we plan to have one of our male associates on with us, but unfortunately he isn't here to represent the men's point of view. What are some of the concerns that you see men in our cohort presenting with? And what kind of advice would you give to them?
Well, I think they present with the normal, you know, diabetes, high blood pressure, heart disease, prostate. So that's, you know, we see that across the board in this cohort. Specifically, you do see a bit more dementia as well in this cohort, and at later stages, you know, so, and it was where, you know, some family member has brought them in, right? So many times they won't come in on their own. Mm-hmm. I think from a cognitive and a mental health aspect, you know, I would hope to see men presenting earlier rather than later.
Yeah.
But I don't know if that answers your question.
No, it's up to you to just make sure, because we have an audience that listens, and we want to make sure people are sensitized to the things that they can do to either stop or improve or avoid, especially with your physical health, your medical issues, because so many of us hide and pretend it's fine. And we really want to make sure that we have an opportunity to lay bare everything that you need to consider and therefore act.
Oh, and then particularly too, I forgot smoking, right? That's a big thing, that you do have women in the later years smoking as well, but not anywhere as near as men, and so they will come in and you'll ask them, what, you're talking to somebody who's in their 80s, and you say, well, what age you started smoking? And they're talking when they were 12. So you're doing 70 years of smoking half pack or more a day every day, So, and lung disease is quite a common thing as you get older, just from degeneration of the lungs, but also when you add on these irritants like smoking, we end up with a lot more things like COPD and emphysema, and more so in men as we get older, related to smoking damage. Okay. So yeah, stop smoking. That's the advice. The earlier, the better.
All right. And I can ask another question linked to, and this is health leading to life, quality of life, because you mentioned earlier the whole issue of how you live onwards. And many of us, we talked about the issue of living alone because your children abroad, they probably went to school and didn't bother to come back, or they migrated for work, or you had a small family and some have gone, spouse has gone, and a lot of us end up alone. What kind of, are you seeing a lot of health issues coming out of aloneness in your practice?
Yeah, I think most of it has to do with depression, with people who are alone. Then the biggest thing is mental health issues. So, and depression being paramount with that, that loneliness is directly linked to that. Many people, I think, who are alone may seek from a physical point of view. They will come and do their checkups because they know they're alone. So if something happens, there's nobody there to think. So they might, from a physical point of view, they will come and make sure they have their medications and all of that. And also coming to a doctor is a form of getting out of the house and seeking other. So it might be you're going to the grocery, the pharmacy, and the doctor, right? That's the only places in lockdown you're allowed to go. So that's where we're going. Yeah. So their physical health might be fine, but other than those times where they could leave the house for brief periods, their mental health is a big issue. So the loneliness and depression is a problem. Yeah. And I think people, we don't realize, and we don't have a culture where, like in more developed countries where we have retirement communities. So yes, your children might be abroad, or you may have chosen not to have children or didn't have children, and you're now in your 70s and 80s, and we living in a house by ourselves. To care for the house is becoming problematic, but we don't have too many things available for us in terms of that sort of assisted living into retirement communities, into maybe more care needs long term. There are very few facilities in Trinidad currently that are catering for that. Mm-hmm. So even those types of things, people who live alone are quite fearful of what if something happens, what if I fall, who am I going to call, so yeah. It really a huge it messes with your head quite a bit when you're alone. Mm-hmm. So
are you seeing on the horizon, given that is the reality, are you seeing an interest, or are you hopeful that more facilities would come on board to cater to this cohort? Because we're talking about the ones coming forward, probably having more active lives, more active careers, being better educated, so are you seeing or hopeful that could be better in the future?
Yeah, I think it definitely could be better, and I do think it will improve. There are some places that try to do it, but our culture still is you're gonna stay at home until you absolutely need it, and particularly the last 2 years, anybody who was considering that move from your own home into a kind of residential kind of facility or something like that, you weren't allowed visitors, there were a lot of restrictions. So I think that, the pandemic has turned off, just put that whole, if you were even considering it before, it's been put on hold. Certainly, in years to come, 5 years, 10 years down the line, there is no reason why we can't have, really well-run retirement facilities with different levels of care. But it is a lot of capital investment and, staffing and lots of, it's a business, and it's a high need business, because the reality is, as morbid as it might sound, but the reality is, unfortunately, we're going to, get sick. We're going to, it's, so it's not, so things have to be put in place that there are different levels of care. Right. And I think that was the gap that we have currently in our situation here. There were places that try to be independent living facilities, but the reality is, what do you do when that person is no longer independent? How do you bridge that gap?
Yes.
And that still hasn't been ironed out. I have not personally found a facility in Trinidad it has really been able to sustain that transition properly.
Yeah.
Places have done it well in certain ways, but to really be, this is where you go from the time you leave your home until the time you go to the next home in the sky or wherever your home will be. That facility does not exist here yet. So maybe some young, energetic entrepreneur might decide that that's a good business investment, but it's definitely needed. It is, as everywhere in the world, we have an aging population. This cohort is only going to get larger over the coming decades, and there are some people who will not have family in Trinidad or have close relatives, and will need that sort of assistance to different degrees.
As they call it, assisted living, independent living into assisted living into totally retirement care. I think those are the key levels. Yes. Yes. And it's real.
Dr. Patience, my final question is following up on what you just discussed. It's on longevity. We are now hearing that, yes, we could live up to 130. 120. My answer to that normally is what the quality of life you would have at that stage. Do you see providing someone do all the things that they are told to do in terms of the exercise, eating well, etc., that could really have enjoy a good quality of life to 120? Let me say 120 years.
I think if we aim to 100, that might be more realistic, but anything is possible. And definitely healthy lifestyle, but also your genetics. People could be the healthiest people, but they're genetically wired. They have heart disease in their family, but they're running up Chancellor every day, and then they drop down. It is, a lot of it, I think, is luck. Genetics, lifestyle. Potentially, are we going to see people living longer and longer? Absolutely. And the hope is that the quality of life is better. I some days, in my job, I say, well, I don't want to live to 120, because what I see that is not quality of life. But that's just the reality. We're not in control of a lot of those things. So all we can do is take one day at a time, live the best we can do, exercise, drink water, get enough sleep, don't hold grudges, and try to enjoy life, and you hope for the best. And if tomorrow is your day, well, good. Hope you had a good life, and trying to aim to 120, that's putting too much pressure on yourself. Just live day by day and hope.
All right. Well, Terry, and I don't know if you have anything before we close on this section.
I think the main things have been covered, and there's one other thing that I want to go back to again, and this comes from my awareness, having responsibility in one instance, it's legal responsibility, and the other, it's parents for older people. And I want to endorse the point that we as people who have access to older persons can't be afraid of finding out what our mental capacities are. And if your GP or your psychiatrist says you need to be tested, I know many people who just don't do testing, just don't, and they continue in fantasies. And later on, because of making arrangements for their care, sometimes you need to have a certificate saying that you really have Alzheimer's or dementia, and there can be legal implications later on. So I don't know if you want to talk around that a bit.
Yeah, I think it's definitely, I spend a lot of time writing medical reports for legal reasons, from as simple as if the bank gets a whiff that you have any memory issues, the bank has the authority to put a hold on your account.
Yes.
And freeze everything. And your $3,000 pension that going into your account, you no longer have access to it, right? Or nobody has access to it. And then you have to go to the court to apply. So the process, and these are lengthy processes. There's nothing in this country happens overnight. So definitely, and this is more for, you know, for the children of, or the guardians, or people who are looking after somebody who may have, even if it is early or late, signs of memory cognitive issues. Those, from the legal point of view, we have really started to crack down now, our government, through the Mental Health Act, that any people who have memory or cognitive issues, who we say, quote unquote, are not of sound mind, as bad as that sounds, they can be easily taken advantage of. And everything that is being done now is to try and prevent that. So from a legal point of view, if somebody has any sort of memory issues, you can no longer do a power of attorney at that stage, right? We are past being able to do a power of attorney. That can only be done when you are of sound mind. You can't do a will when you're already starting to forget. No good lawyer will allow you to do a will. You know, in Trinidad, everything has happened, but it shouldn't. And also, you know, and the process of going through family court and getting that application for committee so that somebody or a group of people are given the authority to make decisions on your behalf is a process. It's a legal process. So it's not that you do those things early if it doesn't need to be done, but specifically to people looking after an older person who has any memory issues, you need to seek the advice of a lawyer and get the person officially tested and a formal diagnosis made, so that, you know, it's not 6 months down when you need to sell the house to pay for their care, you're trying to do those things. It is before, you know, to put things in place so that you could ensure the quality of life of the person is as best as it could be and as comfortable. And it's going to take a lot of strain off of the person who's doing the caring, because they're not having, you know, to be rushed to do all of these things. And putting your finances in place. And there's so many, you know, we could talk for hours and hours. We don't have that time today, but so many things that need to be done. But the legal aspect of it, definitely, you need to have a confirmed diagnosis. As I said before, our Mental Health Act states that it is a psychiatrist that needs to provide the medical report. But certainly if you have a medical report from a specialist, be it a gerontologist or a neurologist, usually the judge will take those, you know, so it doesn't always have to be from a psychiatrist. But the report has to be done for legal purposes, and you make those steps to do things in the right way.
Dr. Patience, I want to really thank you for saying that, because as a lay person, I am aware of it, and I look at people who, I look at us at different stages of the cohorts who have older people in their care, and even when we are conscious and we know there may not be others around, we sometimes sit and say, something will happen. God is good. God is very good, but that's why he allows you to be able to think and be proactive and not sit in fear. But there are real legal consequences. And I think many times you see the elderly abandoned and not well taken care of because someone was too afraid and waited too long.
Yep.
You know, so thank
Dr.
you.
Patience, we thank you so much for, taking time out to come and share with our audience. At this time, as we are doing a series, so we actually have covered the legal aspect, we covered the general aspect, and, we are moving on next week to cover more the care, and, we're having someone from the home to come to chat more. So we really appreciate, I think you covered all aspects, and it's for us, the 5.8G group to really take action, visit your doctors, look at, and go and do all your tests that are recommended, the scans, etc. So thank you so much. And of course, we look forward to always being in touch because of your expertise. So we may be calling on you, or maybe have our clients, our cohorts calling on you, for your advice.
Thanks for having me.
Okay, thanks again. Bye.
Wow, Jennifer. That was a good interview, especially for me because of the nature of the elderly people that I have to take care of. I am so happy that we had Dr. Patience here.
Great. And as I mentioned when chatting with her, our reluctance to go and do blood tests and scans because we feel, look, we know what's happening to us already, and we sort of self-diagnose. So we will say, okay, the pain in the joints is arthritis, or, the headache is because the pressure high. But if we do these blood tests, definitely it will rule out some of the ailments and identify the real problem that we are having. So that, I love her, the fact that she mentioned how important it is to do the blood test, and the idea, your physical, your social, your mental. When we group in those areas, we tend to say, okay, physical, what have I done? Am I taking care of myself? Am I exercising? Am I, what am I doing? The mental I kind of related to, because, as I mentioned again, Mom will be 100 in January, and she does all the puzzles to help us play cards with her, etc. And I feel that definitely has made a difference. I know you talk about genetics, but still, that has made a difference to her. So, and the, that you could do certain tests too, to identify if you may be prone to dementia, Alzheimer's, etc. So such important information, Ariane, that we don't have to guess, or as I say now, all the theories that are going on right now. You say, listen to the science. We have a lot of, we tend to listen to what people say and not listen to the experts, the people who have already studied, the particular area. So for me, Dr. Patience, the interview is so timely within our series, focusing on the elder persons. So I found definitely what she said. There is nothing for me that she left out.
Yeah.
And if you all think she left out anything, you can let us know. but it was a very thorough, impactful interview.
Yeah. I always say, Jennifer, and I different people's circumstances in life are different. And I always tell you that your mom is blessed that she's going to be 100 next January. And is the most important thing. She has 3 children who are here, who are directly involved in her care. One lives with her, one lives next to her, and the other one is a short while away. But on the other side, you have situations where people have no one. The husband died, the children are abroad, and the professional friends, well, you're no longer a professional, so you have no friends, and you're not even able to maintain a home. And that issue that Dr. Patience raised, where you don't have agency for yourself, we assume that someone will take care of us, but we forget that to allow someone to legally take care of you, someone must certify that you are not longer able to take care of yourself. That is and people are afraid to even go to the doctor and say, doc, I'm feeling different. They go to the doctor and they don't want to raise it. And worse, if you are going to a GP, no, let me not say it like that. If your doctor is not a gerontologist, and there are only about 3 in Trinidad, you have to go to a psychiatrist. Listen to me, because it is only a gerontologist or a psychiatrist that will be able to declare your condition, that will allow you to then have guardianship over your loved one or even yourself. People don't know that. So you have to act early. You can't be hiding it. Once you have to acknowledge, I am going to get older and I have to put things in place.
Yeah.
Act, be proactive. Stop being afraid. Be proactive. It will matter to your quality of life later on.
Definitely. And Terry-Ann, next week, our next show, our guests will definitely talk about that decision making, especially when you have no one, or you don't have, you can't remain in your own home, that decision as to, should I, sign in to a home to take care of.
And Jen, we are able to say who that guest is. We are having the chairperson of the Seroptimist Club of Trinidad, well, the chairperson of the Shangri-La Retirement Home, which is run by the Seroptimist Club of Trinidad, to come in, and we're going to have a candid discussion about, and Dr. Patience said, there's not a lot of assisted living existing in Trinidad right now. And for the few that are there, many are there, and the care is good. Let me not buy into the nonsense. Many are good, but a few of them give a very extended and elevated level of care. Yeah. The Seroptimist has a long history of care for the elderly in a residential setting, and we're going to be finding out really what goes on inside of there.
So continue following us. Continue following us. This is a really fantastic series with lots of information being shared.
Yes. Great. So we know what to do with ourselves. We know what to do with the community, and we're going to find out how we can house ourselves. So see you next week.
Just say bye for now.
Bye.
50 Plus Tribe, and follow us from Trinidad and Tobago and the Caribbean.
Thank you for joining us on this Connections 50 Plus 5.8G Alive show.
We hope you enjoyed the lively conversation and look forward to seeing you next week.
Don't forget to like our Facebook page and subscribe to our YouTube channel.
We really love getting your feedback. Bye for now.